Our speaker today is Dr. Daniel Phillips with TOA. He is a native Middle Tennessean, and he is proud of his association with Tennessee Orthopedic Alliance now for more than 25 years, beginning in July of 1988. His focus remains constant to provide the highest level of orthopedic care to his family and his patients. He feels that the best care is achieved by establishing real relationships and partnerships with his patients in the treatment and their orthopedic concern. This is evidenced by his providing care in many instances across generations to multiple family members, from grandparents to children. Excuse me. He graduated as a salutatorian from Gallatin High School in 1975. He then attended Princeton University playing football and graduated magna cum laude in 1979. He then attended Vanderbilt University School of Medicine as a Justin Potter Scholar, the highest award accorded a Vanderbilt medical student, I guess afforded to a Vanderbilt medical student. He graduated in 1983, a member of Alpha Omega Alpha Honor Medical Society, recognition not only of the highest academic achievement but also leadership among his peers, commitment to service, and a firm sense of ethics. He is certified by the American Board of Orthopedic Surgery and has been an active member of the American Foot and Ankle Society since 1995. He has acted as the team physician over many years both at Gallatin High School and Franklin Road Academy. He is also on the North American faculty of AO, Society of Student and Advancement of Trauma Treatment. This is kind of a tongue twister here. He is a member of the medical staff of both St. Thomas Midtown Hospital and Centennial Medical Center. Additionally, he serves in the leadership of TOA on the board as its current president. Outside of his orthopedic practice, Dr. Phillips' primary interest remains his family, his wife of over 30 years, Sherry. Perfect. And his two children, Stuart and Elizabeth. Though no grandchildren as of yet, he does enjoy spending time with his grand pets, including a mischievous Great Dane. Dr. Phillips remains passionately committed to both his personal and professional family. So without further ado, help me welcome Dr. Phillips.
Thank you very much for taking time out of your day to have me up and talk about common foot and ankle problems, which may be a little bit boring to some. I guess we don't think much about our feet until they hurt us, and then we think about them a lot. They're probably one of our more underappreciated and overabused areas of the body. I had a colleague many years ago. I'm dating myself a little bit. I've actually been with Tennessee Orthopedic Alliance now for 31 and a half years. And one of my colleagues had an article in the Nashville Banner. Some of you may be old enough to remember when we had two newspapers in Nashville, and the Banner had an article on foot problems, and his comment was, we never give our feet a second of thought until they hurt, and then we think about them every step we take. So that's kind of the approach we have. I do have some subspecialty interest in foot and ankle problems, so I do provide general orthopedics. I'm one of the last of the Mohicans in that regards, that I cover all bases. And if I can't take care of it, I know somebody in our group that can. We now have over 60 physicians providing care throughout Middle Tennessee, I think 9 different office locations. We're about to open our new office here in Hendersonville, just up the road on the Saundersville exit off Vietnam Veterans. You may be able, I think the sign's up on the building now. We're going to be opening that in mid-November, I think first day, November 18th. We're going to have MRI capability there. In the past, if some of you have been treated through TOA, you may have had to go downtown to get your MRI. You'll be able to get that now here without having to trek downtown. So we're pleased to offer that service and hopefully provide continued excellent care. Some of you may have been treated by some of our doctors here in Sumner County, Dr. Grutter, Dr. Rose, Dr. Cook, and Dr. Ashley. And we hope to provide continued good care at our new location with more convenience to you. That said, I want to cover just some of the very most common problems in foot and ankle problems today that probably some of you have experienced. Just go over some of the highlights of those. Plantar fasciitis is probably the number one most common problem we see. It's estimated to affect between 2 and 3 million people a year in the United States. I had one clinic, I do an outreach clinic in Gallatin. I'll be shifting down to our new office here. But I had one clinic in Gallatin where I had 18 people in a half day, and 7 of the 18 had plantar fasciitis. So it's just a very, very common, almost ubiquitous problem, which most people refer to it as I have a heel spur. Also Achilles tendonitis, which is just next door, and oftentimes those can go in combination or one or the other, and some people feel they have Achilles tendonitis and have plantar fasciitis or vice versa. And then finally ankle sprains, which are a very common injury as well. Plantar fasciitis, again, most common cause of pain on bottom of the heel. As I said previously, approximately 2 million patients treated for this every year. I think I saw only about 200,000 of those last year. So what is plantar fasciitis? Plantar is the bottom of the foot. Fasciitis is a thick band of tissue on the bottom of the foot that originates at your heel and goes out to the ball of the foot. I tell people it effectively acts as a suspension bridge for your arch. So it's very important to your foot function, and you develop pain usually in the area right at the bottom of the heel. A lot of people, when they come in, first say it feels like a stone bruise. Again, I have a number of people who had an x-ray by their primary care physician, and their first statement to me is, I have a heel spur. So that's a diagram of that. What are the risk factors in developing plantar fasciitis? Well, as Americans, we've become more sedentary and weigh more. We still remain two-legged animals, so we put a lot of stress on our feet. I think that contributes to it. We don't stay flexible and supple and active, and then when we have bursts of activity, we injure various parts of our body, the plantar fascia being one. So tight calf muscles, that again is from probably less activity, and we just get tighter as we get older. And one of the last things we do when we exercise, as we get older, we have limited time to exercise, so you jump right out of your car, into the YMCA, immediately start exercising. We don't do any stretching or flexibility, or that's certainly low on the priority scale in terms of our exercise program. But I think it becomes more and more important as we get older that we try to do some things, remain flexible to prevent injury. Certainly weight has a big factor in it. I know I had a bout of plantar fasciitis for about 4 months a couple of years ago, and I think probably some weight gain had a factor in that. High arches, again, it's a suspension bridge for your arch, so I think sometimes a high arch can contribute to it, although also a very flat foot can put stress on the plantar fascia. Repetitive impact activity, again, without maybe appropriate warm-up or stretching. People that start an exercise or running program, I see a lot of different injuries develop, especially since we've had the Nashville Marathon, Music City Marathon, usually starting about in January and February when people are training and increasing their running. We'll have various breakdowns, and plantar fasciitis is one of those that can occur and impact their desired ability to participate in things like a marathon. So newer increased activity. The other thing I see sometimes after people make a trip to the beach and doing a lot of walks on the beach, it's really tough on the feet and legs, and will come home with a flare if they've had it before, or new plantar fasciitis. So this is back to plantar fasciitis and heel spurs. This is an x-ray of a foot. You can see the heel bone or calcaneus, and oftentimes when we take an x-ray at the bottom, there's a spur, and that's right in the area where it hurts. So that leads to people say, I have a heel spur. The heel spur is there, that's true. It usually is not related in any causal fashion to the plantar fasciitis. So they're true, but unrelated. As an example of that, I have patients that have bilateral heel pain, mild in one heel, severe in the opposite heel. And when I take x-rays, the mild side might have a small spur, the severe side has no spur at all. And if we took x-rays of everybody in the room, probably 1 out of 10 people in here would have a spur on their heel on an x-ray. Only of that group that has a heel spur though, so that's 1 in 10, only 1 in 20 have foot pain. So there are lots and lots of people that have heel spur on an x-ray that do not have heel pain, or if they do have heel pain, it's really not related in a causal way. Common symptoms. I don't know, has anybody in here had experience with plantar fasciitis? Raise your hand. So I expected as much. But the common symptoms, I always threaten to make a recording of 2 or 3 patients and just play, is this you? Because it's almost verbatim sometimes. When is your worst pain? When I first get out of bed in the mornings. or if I've been sitting at my desk or computer and I first get up, or I've been sitting in the car and first get out. First few steps just hurt terribly, and then it eases up a little bit. So then, however, if you're active, and especially on your feet, I'm sure a lot of you are on your feet, and sometimes on hard surfaces all day, concrete, different things, gradual increasing pain so that by the end of the day, your foot's really hurting. After maybe you get a little bit of a brief improvement after you first get up, after those real bad pain symptoms at first. In the vast majority of the cases, we can get these better with non-operative treatment. We have a dedicated foot care nurse at our clinic down at our One City office on Charlotte Avenue, and she actually kept track of this for several months. And of the patients we treated for plantar fasciitis, I think with non-operative treatment measures, which sometimes are frustratingly slow, but if you do them consistently are usually effective, 90 to 95% got better with non-operative treatment measures. What does that include? One is rest or alteration in your activity level that's causing the problem. Stretching, that helps with the tight calf muscles and helps with your flexibility, so it puts less stress on the plantar fascia. Foot massage, those first few steps that hurt when you first get up, if you get your foot loosened up and massage it and things before you get up, when those first few steps that hurt real badly is when you're doing the damage or causing micro tears in that plantar fascia. So if you can limit that damage that you experience the first few steps, it gives your body a better chance to heal. Icing, we freeze a water bottle, and after you do your stretching, roll your foot on a water bottle, again decreasing inflammation in the tissues. If the inflammation is too much, it really prevents healing of the tissues, so you want to limit it at just the right amount to allow appropriate healing. Cortisone injections, depending on severity of your symptoms, probably some of you may have had cortisone shots. Some people say they hurt a lot. Some people say they don't hurt that badly. I haven't had anybody not survive one yet. But they are very effective. I wouldn't recommend them if they were not effective. And sometimes if you have a severe case of plantar fasciitis, all the other measures are very slow and marginally effective. If you add the cortisone injection, then people really see quicker improvement with the other measures more effective. Anti-inflammatories, again, limiting inflammation in the tissues. Again, you have, the downside of the anti-inflammatories are potential side effects with stomach upset or that sort of thing. And then supportive inserts and night splints. Night splints keep you in a stretched position. I have a lot of patients who are unable to well tolerate a night splint, or they'll kick it off after a couple hours, but sometimes I have people who will just wear that in the evenings for an hour or two while they're watching TV or at the computer just to keep their foot in a stretched position, again improving flexibility. Supportive inserts, a lot of shoes we wear don't really give us a good foundation or support to that longitudinal arch of the foot. The inserts that I've been recommending to people are all available commercially at a reasonable price. I kind of qualify these as semi-custom inserts. You don't have a mold of your foot and a custom insert made, but the brands there are Power Step, Superfeet, which I've seen at REI, and the ones that I've recommended a lot and have been very effective for a lot of my patients that I've only seen online are the Protalus, the 3/4 length, which is you can use in a shoe a little bit better so it doesn't crowd your toes, is the M75 insert. The cost of those, Protalus is probably the most expensive of those three. The Power Step and Superfeet are on the range of $40 to $60. The Protalus, with the discount coupon I always see online, is right at $79. But that's in comparison to, I know there are some stores in Nashville, we won't mention any names, that advertise heavily. They put people on payment plans because they have a series of custom inserts, and what I've seen, they're not really that custom, and the cost is on the range of $1,200 to $1,400. If we do go a custom insert route, which I have on some people that have a recalcitrant case of plantar fasciitis, I've got a girl at a Hanger Clinic that's near our office in downtown Nashville, and she is the best person at making inserts I've ever worked with in Middle Tennessee. Hers are truly custom inserts, and that means adjusting them multiple times after you get them if necessary, and the cost when you go to that level is right at about $400. And I mention that because a lot of times insurance does not cover DME or durable medical equipment or inserts, even though it's a medical problem. So in the small group of people that fail to improve with conservative measures, and usually conservative measures we will work with them for on the range of even 4 to 6 months before you really fall into the category of what are our other alternatives in treatment. There are operative treatment options. Those two treatment options are the extracorporeal shockwave therapy, which is a high energy ultrasound treatment. Oscitron is the name. It does not require an incision. It does require surgery in that you're at the surgery center and you have to be sedated because otherwise that high energy ultrasound will feel like somebody was hitting the bottom of your heel with a hammer. So you probably would not enjoy that. So you are essentially put to sleep for that surgery, but no incision. And usually see improvement in those people in about 60 to 75% of people. You have to limit your activities significantly for a few weeks afterwards to allow healing. What that does, that high energy ultrasound stimulates new vascular ingrowth into the tissues to help the tissues heal. And then after the Oscitron procedure, usually we have you restrict your activity level to about half normal, wear good supportive tennis shoes, that sort of thing. Sometimes even use crutches the first few days. But again, moderate restriction in activity level for about 4 to 6 weeks. And during that time frame, you avoid taking any anti-inflammatories because what that does is it stimulates inflammation and vascular ingrowth, so we don't want to interfere with that process. But overall recovery, where you're going to see is that effective or not, is about 4 to 6 weeks. And then the second, which I think is a little bit more effective than the Oscitron treatment, but does require an incision, is plantar fascial release. We talked about the damage to the plantar fascia is repetitive micro tearing of those tissues. So the plantar fascial release is usually a small incision on the inside of your heel where we actually go in and we cut across the plantar fascia to release it, take tension off of it, and allow it to reset itself at kind of a new, more relaxed position. The one thing I see after that sometimes is the arch of your foot settles just a little bit, not so that you can notice it, but enough that sometimes you have a little bit of aching in the foot even for 3, 4, 5 months afterwards, even though you've had relief of the plantar heel pain. So it takes your foot a little while to adjust to that. That does require an incision, and so you have the additional risk of things like a wound infection. But I see that be a little bit more effective. I tell people usually with the open plantar fascial release, 80 to 85% or 80 to 85% better. So that covers plantar fasciitis. Let's go on to back to the heel now, Achilles tendonitis, which we see very frequently too. And this involves the Achilles, either in the mid-substance of the Achilles or right where it attaches at the posterior heel. This is associated with a bone spur. So the bone spur oftentimes does contribute to the problem. I think the bone spur in the Achilles situation tends to develop over time due to the chronic inflammation of the Achilles, and you actually get that spur is within the substance of the Achilles. And a lot of times then you can get a significant prominence on the back of the heel, which is called a medical term is a Hagelin's deformity. A lot of people, women see that a lot that wear the high heels with the real stiff heel counters, and the lay term for that sometimes is called a pump bump. So they get sometimes a very prominent bump on the back of your heel that makes it difficult to wear shoes with a closed back. Treatment is similar in a lot of ways to plantar fasciitis, stretching again to improve flexibility, icing, anti-inflammatories. Sometimes in the Achilles area we use topical topical anti-inflammatory cream that's effective so you don't have as much of a risk of GI side effects. On the heel with Achilles tendonitis, and we see this, you should always try to avoid having someone give you a steroid injection in the area of the Achilles. The steroids can weaken the tissues, and has been a clear association with steroid injections for Achilles tendonitis and subsequent rupture of the Achilles tendon. As I see a lot of foot problems, I've had a number of patients elsewhere had steroid injections and came to see me when the Achilles had ruptured. On the plantar fascia, sometimes that can occur, but again, if that occurs on the plantar fascia, that's what we do with surgery, is we release the plantar fascia. So it's not as catastrophic a complication, and actually can treat the plantar fasciitis if you get rupture of the plantar fascia. But the Achilles is not a good thing to have a ruptured Achilles. Also, if you're having symptoms at the Achilles, it's not a good thing to ignore that and be an ostrich, because people usually, a lot of people in the age group 30 to 60, So our bodies are less resilient, but we're still very active. If you're having Achilles pain, that's a warning sign that your Achilles could be at risk for a rupture. And I have a lot of people will be playing softball or basketball or things. The typical is softball, I was running at first base and I thought somebody hit me in the back of the heel with a softball. And that's when their Achilles ruptures. And if you ask them, well, it had been aching and hurting some for the 3 or 4 weeks before that happened. So if you have Achilles pain, absolutely be proactive in treating that. Sometimes we have to rest the Achilles to allow it to recover, which involves a walking boot, or even more significantly, sometimes a walking boot is effective, but it does not completely immobilize you. Sometimes in more severe cases, we actually put people in a cast to fully immobilize them 24/7 for even 4 to 6 weeks. Operative treatment with the Achilles, you can see sometimes when you develop that prominence in the spur, it just does not improve. And we go in and clean the Achilles and clean the spur out and then reconstruct the Achilles. I tell people a lot of times we're taking the Achilles apart and then putting it back together. So it's a long recovery, because if we do that, we're doing a controlled rupture of the Achilles, and so your recovery afterwards is almost the same as if you had the Achilles rupture and you have to protect it. That's one of the biggest complications of that surgery, is to have a post-operative rupture of the repaired Achilles. Also, in the back of the heel, you can imagine there's not much tissue back there. And when you feel your Achilles, it's skin, and then the Achilles tendon is right there. There's not a big muscle covering or anything. So any wound healing problems in the back of the heel can be very, very difficult to treat and can require long treatment periods at wound care centers, that sort of thing. That occurs very infrequently. Most people say on the range of maybe 2 to 5%. We worry more about that in people that with diabetes or especially smokers. Can impact wound healing. And that's a big worry, especially when you're operating on the Achilles. Ankle sprains. Who here has had an ankle sprain at some point? Again, about half the room. Ankle sprains involve tough bands of tissue that stabilize the bones of the ankle. Those are ligaments. Those tough bands of tissue that go from bone to stabilize the joint are called ligaments. When you have the tough bands of tissue that go from a muscle to a bone, so that's at the end of a muscle, is a tendon. So these are the ligaments of the ankle. Most commonly involve the outside or lateral part of the ankle. And the most common injury is when you roll the ankle inwards, where your ankle turns on the inside. It's less common to have it go the other way when you think about you're stepping off a curb or something uneven. And you see that when they show the slow motion of the injuries in athletes. A lot of times the ankle rolls to the outside and injures those outside ligaments. This is a depiction of that. That's the position of the foot and ankle with most ankle sprains. And you've got the primary ligaments on the outside of the ankle. The most common one is that anterior talofibular ligament, which is the most inferior, and that's right at the anterolateral ankle. So that's a little bit in front of the bone on the outside of your ankle.
What's the difference in like a common ankle sprain versus a high ankle sprain? You hear that a lot?
Yeah, we'll talk about that a little bit. Would be the common ankle sprain is a low sprain. You have a thick ligament that goes between the two bones in the leg, the fibula and the tibia. And when that is involved, then you're much more tender and swollen above the ankle. That injury is a more serious injury, can sometimes even involve a fracture of the outside bone. And on those, we have to protect those longer. If you recognize a high ankle sprain, the worst thing you can do is try to start immediate therapy. It just prolongs the recovery. A lot of times a high ankle sprain, we put into a boot right away and limit weight bearing. And 2 to 3 or 4 weeks, as the pain subsides and that heals, then you begin therapy. With the lower ankle sprains, a lot of times we can begin therapy almost right away to speed the recovery. And many sprains can be self-treated. It's always a judgment call on when do you need to go see the doctor, or can I see, so what's the primary treatment? And this is true of a lot of different sprains and strains, not just at the ankle but other parts of the body, is the RICE treatment. Rest, ice, compression, which helps minimize swelling, and elevation, which also helps minimize swelling. By elevation, I always tell people the heart's the pump, water runs downhill, simple concept. So I see people that are at their desk and they propped their foot up on a stool, I kept it elevated, and it still just swelled up like you wouldn't believe. Well, you were still well below the pump. To really elevate something is almost on your back, with it up on the back of a couch or in a recliner and up on some pillows. So you want to be, and we do that after surgery too, when we're telling people to elevate higher than the heart, higher than the pump, so water runs away from the extremity. And again, early on, anti-inflammatories to help with pain and inflammation. When to seek medical care. That's always, I had that, about 3 weeks ago. I was out of town, but my daughter called me. She stepped off the curb, sprained her ankle. She called, she said, "You picked the worst time to be out of town." But when to seek medical care, and I said, well, send me a picture on the phone, point where it's hurting the most, that sort of thing. Where she was trying to decide whether to go to the ER or not. Pain is severe or uncontrolled despite some of that initial self-care. So it's always a spectrum there to make a judgment on when you might need to seek care, especially immediately. So other kind of tips that might suggest that you need to get on in and get that checked rather than waiting a few days. You can't walk or cannot walk without severe pain. Although I have had people, it's not true that if you can put weight on it, does not mean that you don't have a significant injury. I have people that hurt pretty bad, but I could put weight on it, so my friends told me there was no way it could be broken. Same things with Achilles ruptures. I've had people come in even 3-4 weeks after the injury. I could put weight on it, so they said it couldn't be ruptured. It was ruptured. Or you have a broken ankle. So you can walk on a broken ankle. I see people sometimes 2 and 3 weeks have been walking on a broken ankle, and then they finally come in because it's not improving. The general time frame, though, when you're looking at things, if you don't, mild to moderate sprains usually will show pretty good improvement the first 5 to 7 to 10 days. So if you do something and it's really not seeing real improvement in that time frame, you should consider getting it checked. This is more when to really, do you need to go to the ER right now? So again, it's a spectrum, severe or uncontrolled pain. If it looks like your foot or ankle is pointing the wrong way or misshapen or extreme swelling. Now with an ankle sprain, you'll get an immediate little goose egg right at the ankle, but I'm talking about the whole ankle and lower leg just immediately blows up. That might be indicative of more significant injury. Now also, pain when pressing on the bone at the inside or outside of the ankle. If you feel your own ankle, you've got 2 bony prominences there. One on the inside is the medial malleolus. One on the outside is the lateral malleolus. If you press directly on the bone after a sprain, and that's where it's hurting, that might be more indicative that you have a fracture. An ankle sprain, usually if you press on the bone, it doesn't hurt too much. If you press, what I said initially, just in front of the bone at that anterolateral ankle, that's where it's tender. That's over the ligament. But if you're tender directly over the bone, that sometimes is more concerning and when you might want to get checked early. Questions? Again, I want to thank you for coming up. I think the Green Wave are playing the Commandos this Friday night, I think. Now, I'm old enough, I played when we had leather helmets and no face masks. And Johnny Carver, I think, was a quarterback for the Commandos. There was no beach or station camp then. Johnny Carver was a quarterback, and they got us my junior year, but we returned the favor my senior year. So, any questions?
Is this true that if you change shoes, it helps with plantar fasciitis?
Well, I think sometimes where people are wearing shoes that are really worn down. So yeah, if you change shoes that have a good cushion outsole and a good arch support, getting a new pair of shoes can be helpful, yeah. Especially if you're...
If all your shoes are good, is it good to switch them up? Or?
Yeah, I think not wearing the same shoe every day, because then it kind of supports your foot a little bit different and you don't get the same stress in the same area every day. I think it's a good thing to have some shoes that you rotate, absolutely.
How long would you say that a pair of tennis shoes is good for? 3 months, 6 months?
It depends on the activity level. Now, if you're a big runner, a lot of those people replace their shoes every 2 to 4 months if they're really doing a lot of mileage. I think a regular tennis shoe that you're wearing, not every day, but a moderate amount, they kind of lose their oomph and things probably in 6 to 9 months. Although I certainly wear some longer than that, but till the dog chews on one. Again, thank you for having me. Hope it was informative for you.
All right, thank you.